It was a frightening time. It was a very, very lonely time. Grief is lonely anyway. But grief at that time was so compounded by the absence of comfort, of closeness, of other humans. I used to be a nurse, so I know what a good death is. And I wasn't able to give Dad that. It was hard. It was hard for so many people. I think everybody suffered somehow.
In Northern Ireland, a wake is a very important part of the grieving process. That didn't happen. I don't go to the cemetery now, because when I go to the cemetery, I see the red and white tape. I see the men in their white suits and their masks. I see them putting their hand up, telling me I can't go towards the graveside. I relive that. I hear them telling me our time is up. You know, our time was up. We all had to walk off individually and go home to our own houses. There was no coming together. My mum didn't get a celebration of her life. And as a daughter, that makes me feel I failed her.
The worst impact this had was on my frail elderly parents who lived in India. And my mother passed away in 2021 and my father followed her in 2022. So my illness had such a severe impact on my family, on my parents. And I always feel if this hadn't happened, my parents might still be there now.
Our family were denied all the usual bereavement rituals, which has left us with the guilt that we couldn't pay tribute to our father, that those that loved him couldn't show their respects. It also left us as a family very isolated. For example, it was 6 months after Daddy died that my mother first got a human hug.
8 people at the funeral. My mother, 83-year-old, sitting 2 metres away from us, sitting in deathly silence. And the next thing we hear is this old steel rattle-tattle coming down the crematorium, and everyone is turned around and looked, and there was my brother getting rolled in his tattery old steel trolley. The noise I'll never forget. That noise I'll never forget. And that was it. I mean, people can read things out of a textbook and say, well, I know how you feel. Nobody knows how we feel. Nobody. Until actually, if you're sitting in my shoes right now, then you'll be able to say, I know, but nobody knows how I feel. Our lives are just broken. We try and go on through each day, you know what I mean? But I've lost everything.
You know, it's just not what you expect. It's terrible when somebody that you love dies, but to not help them make their final journey perfect and lovely really hurts. And that you can't give them the send-off that they deserve really hurts. It's something I will never, ever get over. And the time that he needed me most, I wasn't there. And I felt guilty about that, even though it wasn't my fault.
You couldn't be there with them to hold their hands. You couldn't see them when Dad died. You can't really organize a proper funeral. You can't gather together and mourn and be with other people. You're just alone. You're just alone. I still suffer from anxiety. I still wear my mask everywhere I go. All I can say is you don't know when it's going to get better. We learn to live with it, but you don't know when it's going to get better.
It's left me, I think, both myself and my mum with, a great amount of guilt and trauma and pain, particularly about what happened.
In the Caribbean culture, I've got to say, when there's a funeral, you're talking about hundreds of people easily. They were telling us 20 people could attend a funeral. We gave the best send-off we could, but that's not the way he would have been sent off on a normal day. No way. They had the bodies in bags that you couldn't even give them an outfit to bury your family in an outfit. They said they're in a zipped bag and it's got some lock on it and they're not allowed to break the lock. I'm angry. I need questions answered. I'm just still hurt and I'm still upset. And it's been a couple of years now and we're still upset. And it's not going to go away just like that.
The grief I have is my love. And I just need to find a way to channel it. I think it's a very important part of history. And history has to reflect the truth of what happened to families like mine.
And I am so aware that society are so tired of the whole thing. But for us, those missing parts, they're there for a reason in the grief process. And there's no way to navigate around those things. You have to go through those, and being denied those, it's a vital part of us being able to move on. And ultimately, in order for us to move on, we need to know that lessons will be learned and that future generations will be safeguarded from the heartache that we have had to suffer.
I hope that those who had to leave the room will be able to recover as soon as we're able to reassemble. We shall do so. Could we send a message to them, please? Ask them if they wish to come back in. I'm sorry to all of those who found that film particularly distressing. I think it was distressing for everybody, but I'm sure especially so for you. So I'm sorry about that. Mr. Keith.
My lady, we will likely never know how the severe acute respiratory syndrome coronavirus 2, more commonly known as SARS-CoV-2, the virus that caused the Covid-19 pandemic, was first transmitted to the human race. Perhaps it came from farm wild animals that were transported to and then sold in the live wet market in Wuhan, the capital city of Hubei province, China, infecting market workers and customers. Some have suggested it came from a leak of coronavirus specimens being transported to or stored at the Wuhan Institute of Virology. We will also likely never know when the first human infection with SARS-CoV-2 occurred. Minute retrospective examination by scientists of how the genetic sequencing of the virus altered over time suggests that the dates of its emergence could have been any time between mid-October 2019 and mid-December 2019. Certainly, the first reported case, reported after the event, was the 12th of December of 2019. But, my lady, for this inquiry's purposes, this knowledge does not matter. What we do know is that the United Kingdom, as with the rest of the world, was struck by a major pandemic. As with all pandemics, the COVID-19 pandemic left in its wake death, misery, and incalculable loss as the impact film that we have just seen, in which we heard from just a tiny proportion of those whose loved ones had died, demonstrates so poignantly. The pandemic did not just alter fundamentally how modern societies across the globe functioned, but ended and changed lives on a scale unseen in modern history. No inquiry, however large or however long, could possibly inquire into all aspects of a pandemic that wrought such damage. And your inquiry does not seek to do so. You have instead determined that it will focus on those areas of the pandemic and the United Kingdom's response to it that have caused the greatest public concern, and where there may be a need in the public interest to make urgent recommendations so that we may be better prepared in the event of the next national civil emergency to befall us. That module starts today, Module 1. It commences that process. It investigates what the state of the whole country's emergency preparedness, response and resilience structure and systems were when the pandemic struck in January 2020. My lady, I therefore need to set out the briefest of chronologies because it's important to appreciate and understand, before we hear the evidence concerning the decade before the pandemic, what the reality was in January 2020. So, in late December 2019, a cluster of cases of pneumonia of an unknown origin was detected in Wuhan City, Hubei Province, China. A new strain of coronavirus was subsequently isolated on the 7th of January 2020. It was identified as SARS-CoV-2. On the 10th of January in the United Kingdom, the Department of Health and Social Care, the DHSC, published guidance for health professionals on the assessment and management of suspected United Kingdom cases. On the 21st of January, the World Health Organization published its novel coronavirus 2019 nCoV Situation Report 1. This is the date, in fact, at which the period covered by Module 1 ends. The Situation Report 1 recorded that as of the 20th of January, 282 confirmed cases of 2019 nCoV had been reported from 4 countries, including China, Thailand, Japan, and the Republic of Korea. On the 30th of January 2020, the second meeting of the International Health Regulations Emergency Committee of the World Health Organization declared a public health emergency of international concern, but it's notable that they recommended no travel or trade restrictions. The virus and the disease, COVID-19, spread rapidly. The United Kingdom Scientific Advisory Group for Emergencies, SAGE, convened for the first time on the 22nd of January, and the Civil Contingencies Committee, COBRA, met on the 24th of January 2020. The Foreign and Commonwealth Office issued its first travel advice on the 23rd of January. The first 2 cases of COVID-19 in England were confirmed on the 30th of January, and on the same day NHS England declared a serious level 4 incident. By the end of January, it was becoming apparent, and my lady, the degree to which it was apparent is of course a matter for Module 2, that the disease was a respiratory disease which was asymptomatic, meaning that a person infected by the virus might not show any symptoms of it, and for which there was no ready test, no antiviral medicine, no immunity, and no vaccine. On the 15th of February, France recorded the first official death in Europe from COVID-19. By late February, the number of cases outside China had increased 13-fold, and the number of affected countries had tripled. A worldwide public health emergency was underway, although a pandemic was not in fact declared by the World Health Organization until the 11th of March. The first positive cases in Wales and Northern Ireland were reported on the 28th of February and in Scotland on the 1st of March, although that case related to an outbreak that had occurred a few days earlier, a conference that had occurred on a few days earlier on the 26th and 27th of February. The first death in the United Kingdom, a woman in her 70s, was confirmed on the 2nd of March. On the 3rd of March, the DHSC, the Scottish Government, the Welsh Government, and the Department of Health in Northern Ireland published a coronavirus, COVID-19 action plan, setting out how they plan to tackle the coronavirus outbreak. Based on the experience of dealing with other infectious diseases and the influenza pandemic preparedness work that had been carried out, the plan stated that the United Kingdom was well prepared to respond in a way that offered substantial protection to the public. Whether that was actually the case will be examined in Module 1. And of course, that is why Module 1, in terms of preparedness, in terms of the response that was expected, that is the focus of your examination. And even at this stage, before hearing the evidence, it is apparent that we might not have been very well prepared at all. On the 4th of March, the DHSC in England announced a campaign focusing on the importance of washing hands, and washing hands for 20 seconds, using soap and water or hand sanitizer. On the 6th of March, the United Kingdom government announced significant additional funding for rapid diagnostic tests and for the International Fund into Vaccine Research. On the 11th of March, the then Chancellor of the Exchequer, Rishi Sunak MP, announced a package of emergency support, including the establishment of a £5 billion emergency fund to support the NHS and other public services in England, and additional NHS funding, measures for additional access to statutory sick pay, contributory employment support allowance, a hardship fund for local councils, and business interruption loans. On the 12th of March, the then Prime Minister Boris Johnson MP announced that the United Kingdom had moved into the delay phase of the coronavirus action plan. My lady, you will recall that he informed the country that many more families were going to lose loved ones before their time, and he announced that as part of the attempt to delay the spread of COVID-19, anyone with symptoms, however mild, should stay at home for at least 7 days. It is absolutely clear now, with hindsight, that the disease was spiralling out of control. But to what extent was that possibility foreseen, planned for, and guarded against? How ready were the public health structures to deal with this possibility? The reality was that the United Kingdom government announced it would stop all community testing for COVID-19 and focus instead on testing people in hospitals and protecting health workers as it moved from the contain phase to the delay phase. So it's clear that the system had not adequately foreseen and prepared for the need for mass testing in the event of a non-influenza pandemic. For a flu pandemic, of course, you're most likely to show symptoms. You know you have a bug. You go home, possibly to bed, and you try not to pass it on, and tests aren't needed. On the 13th of March, the then Welsh Minister for Health and Social Services, Vaughan Getting, MS, announced the suspension of a number of NHS services to allow for services and beds to be reallocated and for staff to be redeployed and retrained in priority areas. On the 16th of March, the number of deaths in the United Kingdom rose to 55, with 1,543 confirmed cases. But the likely number of infected cases was probably over 10,000. There was no antiviral medicine and no national pandemic flu service to prescribe it, for the simple reason that COVID-19 was not an influenza virus. The United Kingdom government commenced daily press conferences. The Prime Minister announced anyone with a high temperature or a new and continuous cough should stay at home for 14 days and not go out even to buy food or essentials. The country was told to stop non-essential contact with others and to stop all unnecessary travel, to start working from home where they possibly could, and to avoid pubs, clubs, theatres and other such social venues. The same day, the Department for Business, Energy and Industrial Strategy issued a statement calling for businesses to support it by supplying ventilators and ventilator components across the United Kingdom. My lady, you have directed that we ask to what extent had the system envisaged and prepared for the need for mass provision of personal protective equipment. On the 17th of March, the Chancellor announced £330 billion worth of government-backed loans and £20 billion in tax cuts and grants. The Foreign and Commonwealth Office advised against all non-essential international travel. France imposed a nationwide lockdown. The then First Minister of Scotland, Nicola Sturgeon, MSP, made a statement to the Scottish Parliament setting out the stringent steps that were required to be taken. The NHS England Chief Executive, then Sir Simon Stevens, and the NHS England Chief Operating Officer directed the NHS in England to take measures to redirect staff and resources to free up inpatient and critical care capacity. These included the postponement of all non-urgent elective operations, the urgent discharge of all hospital inpatients who were medically fit to leave, and the block buying of capacity in independent hospitals. Was this need for surge capacity something that had been adequately prepared for? On Wednesday, the 18th of March, the then Secretary of State for Education, Sir Gavin Williamson, MP, announced the closure for the end of that week of schools other than for children of critical workers and vulnerable children. Exams and assessments were later cancelled. The Scottish First Minister, the Welsh Minister for Education, Kirsty Williams, MS, and the First and Deputy First Ministers for Northern Ireland, Baroness Arlene Foster, MLA, and Michelle O'Neill, MLA, made similar announcements. But how developed were those plans for school closures? On the 19th of March, the Department of Health and Social Security and the Ministry of Housing, Communities and Local Government provided further details of how a £5 billion support package would be given to local authorities. The Defence Secretary, Ben Wallace MP, announced that up to 20,000 MOD and service personnel would be placed on standby to support public services, including by way of driving oxygen tankers around the United Kingdom. On Friday, the 20th of March, the Chancellor announced the Coronavirus Job Retention Scheme and payments of grants backdated to the 1st of March of up to 80% of furloughed workers' salaries. My lady, cafes, pubs and restaurants were requested to be closed from that night, and nightclubs, theatres, gyms and leisure centres as soon as they reasonably can. In separate televised addresses, the then First Minister of Scotland and the First Minister of Wales, Mark Drakeford, MS, made similar appeals. At 5 p.m. on that Sunday, Public Health England figures showed that there were 5,683 cases of COVID in the United Kingdom and 281 deaths. At that time, the data referred only to deaths in hospitals and didn't even include deaths in the community, in care homes or in hospices. There'd been a rise of 48 deaths since the previous day, 37 in England, 7 in Wales, 3 in Scotland and 1 in Northern Ireland. The weekly provisional figures for deaths registered in England and Wales with COVID-19 as an underlying or contributory cause, calculated by the Office for National Statistics, was 103 for the week ending the 20th of March and 539 for the week ending the 27th of March. On Monday, the 23rd of March, we will recall that the Prime Minister announced severe restrictions on the entirety of the United Kingdom in what became known as the first national lockdown. On the 24th of March, the Senedd, the Welsh Parliament, agreed to a legislative consent motion on the coronavirus bill. On the 25th of March, the Coronavirus Act was passed by the United Kingdom Parliament and received royal assent. It had passed through all the stages in the House of Commons procedure in a single day. And then on the 26th of March, the lockdown regulations were introduced. The Health Protection Coronavirus Restrictions England regulations were introduced by way of a statutory instrument made by the Secretary of State, Matt Hancock, Member of Parliament, using emergency powers available to him under the Public Health Control of Disease Act 1984 and the regulations came into effect the moment that they were made at 1 p.m. on the same day. Analogous coronavirus restrictions regulations were made in Scotland and Wales by the Scottish ministers and the Welsh ministers. On the 28th of March, health protection coronavirus restrictions regulations were also made by the Department of Health in Northern Ireland. I mention, my lady, the various regulatory structures because one of the work streams that had been progressed in the years leading up to the pandemic was one of working on a pandemic bill, a draft pandemic bill, to cover for the eventuality of a pandemic striking the United Kingdom. But in the reality, the lockdown regulations that were made in England were made under a 1984 Act, the Public Health Control of Diseases Act, in Scotland under the Coronavirus Act, and in Northern Ireland under a 1967 piece of legislation. That day, the 26th of March, the daily death toll went up by 115. The pandemic had the country in its grip. Almost every area of public life across all four nations, including education, work, travel, the majority of public services and family life were adversely affected. The hospitality, retail, travel and tourism, arts and culture, and the sport and leisure sectors effectively ceased. Even places of worship closed. My lady, as you know, for very many, what they had to deal with went far beyond the curtailment of their normal lives and involved bereavement, serious illness, deprivation, mental illness, exposure to violence at home, terrible financial loss, loneliness, and many other forms of suffering. Health and social care workers, the police and the emergency services, transport workers, teachers, and other key workers continued, however, in their places of work, and they put their own lives on the line in terms of their safety. The months and years that followed, we all recall, saw death and illness on an unprecedented scale. But I don't need to set out, even in outline, the events that followed. The lifting of the first lockdown, the further lockdowns, the local restrictions, the gradual differences of approach between the United Kingdom and the devolved administrations, and finally the route out of the pandemic afforded by the gift of vaccines. That is because, for the purposes of this module, the state of preparedness must be measured against the reality of when the pandemic first struck, January 2020. It's my solemn duty to record that government figures state that up to the 12th of May 2023 in England, there have been 192,231 deaths where COVID-19 was recorded on the death certificate. In Scotland, the figure is 17,603. In Wales, it is 11,848. And in Northern Ireland, 5,295. Making a total across the United Kingdom of 226,977 lives. My lady, by the measure of excess deaths or excess mortality, that is to say the number of deaths from all causes, over and above what would be expected under normal conditions had the pandemic not occurred, so capturing not only confirmed deaths, but also COVID-19 deaths that were not correctly diagnosed or reported, as well as other causes that are attributable to the pandemic, the figures are likely to be higher still. Research reveals that mortality rates were significantly higher among people with pre-existing conditions, such as dementia and Alzheimer's disease, heart disease, high blood pressure and diabetes. Shockingly, mortality was 2.6 times higher in the most deprived than the least deprived tenth of areas. People from some ethnic minority groups had a significantly higher risk of being infected by COVID-19 and also from dying from it. COVID-19 mortality during the pandemic was highest in people from the Bangladeshi, Pakistani and Black Caribbean communities. And mortality rates were higher among people with a self-reported disability or a learning disability. And so the big question for Module 1 is to what extent were those terrible outcomes either foreseen or capable of mitigation. My lady, the pandemic has had profound financial and economic consequences. It's put national health systems under enormous and continuing pressure. The impact on the healthcare systems, its operations, its waiting lists, and on elective care has been immense. Millions of patients have either not sought or received treatment, and the backlog has now reached historic levels. Jobs and businesses have been destroyed, and livelihoods were taken away. The pandemic disrupted the education of children and young people, put children at risk, and has left us with an enduring concern that the pandemic furthered disparities in attainment and development. The pandemic impacted the most disadvantaged communities in society all the more, both in terms of the consequences of getting the virus and in terms of the steps taken to combat the virus. Societal damage in terms of the exacerbation of inequalities and the denial of access to opportunity has been widespread. Its impact will be felt for decades to come. My lady, the emergence of this natural disaster could not have been avoided. But the key issue is whether that impact that I have described was inevitable. Were those terrible consequences inexorable, or were they avoidable or capable of mitigation? The starting point for your inquiry is that whilst we may not know the moment that this virus came into existence, or how exactly it made its way into the human race, we do know that the possibility of a pandemic had been foretold and thought about. Indeed, it had long been assessed by planners that there was a significant risk of a non-influenza pandemic and an even greater risk of a flu pandemic. Such risks were assessed and thought about and planned for and prepared for and written about by the departments, bodies, agencies, services, responders and personnel who make up the United Kingdom's emergency preparedness, resilience and response structures, the EPRR structure, the first major acronym to which it's my unhappy duty to refer in an area infested by acronyms. But fundamentally, in relation to significant aspects of the Covid-19 pandemic, we were taken by surprise. Huge, urgent, and complex policy decisions were required to be taken in relation to shielding, employment support, managing disruption to schools, borders, lockdowns, and non-pharmaceutical interventions, restrictions, social restrictions, and equally importantly, the profoundly unequal impact of the pandemic on the vulnerable and the marginalised. Few of those areas were anticipated, let alone considered in detail. My lady, no amount of foresight or planning can guarantee that a country will not make mistakes when a disease strikes. But that does not mean that we should not strive to be as ready as we sensibly can be. No country can be perfectly prepared, but it can certainly be underprepared. And so it is to the adequacy and sufficiency of those structures, the plans, the steps taken to prepare, and the degree to which the country was resilient, that is to say, able to respond and bounce back, that this first phase of the COVID inquiry turns its attention. Module 1 will ask, were the right EPRR structures in place, the right procedures, the right plans? Was the system of central, devolved, regional and local government response available and ready to go? Did civil contingency planners think carefully enough about the risks of a pandemic and how they could best prepare for the crises which might develop from those risks? Module 1 will look at whether the EPRR system was effective and practical, that the bodies and structures that populate it were fit for purpose and not duplicative or obsolete. We will ask whether the system was designed to work well under pressure, whether it gave responders, nationally and locally, the proper tools to respond with. We want to know whether the policy documents and planning guidance were useful and not tarnished with bureaucracy or prescriptive overmanagement or jargon. Most of the evidence over the next 6 weeks will be concerned with those issues. My lady, standing back, there can, however, be no proper scrutiny of the pandemic planning, with which, of course, you are primarily concerned, without a simultaneous detailed examination of the actual civil emergency structures upon which pandemic planning rests, because pandemic planning is, of course, just a feature of the wider civil emergency structure. And so, my lady, the inquiry will be looking at whether as a nation we were sufficiently resilient. Resilience is related to capacity and concerns the ability of a country to resist, absorb and recover from shock. The ability to recover is closely connected to the general health and wealth of the country as a whole. It is for this reason that part of the module, as well as later modules in your inquiry, which will focus specifically on inequalities, will explore what state the nation was in as we entered the pandemic. Did the high levels of heart disease, diabetes, respiratory illness and obesity render us more vulnerable? Had there been a slowdown in health improvement in the decade before? Had health inequalities widened? Did emergency planning sufficiently account for pre-existing health and societal inequalities, deprivation, structural racism, and other forms of discrimination which undoubtedly exist in society? As for wealth, it is self-evident that the capacity of any country's public health care and social care systems to be able to cope with the pandemic is constrained by funding, and therefore you need to inquire how well funded were the United Kingdom's health structures, to what degree have our public services, especially those of health and social care, suffered from underinvestment, how well resourced were the United Kingdom's public health structures. My lady, these questions must be asked. This is not because it lies in the power of your inquiry to resolve them. The inquiry plainly cannot of itself bring about general improvements in health, social care or public services, let alone direct that they be made. The questions must be asked because I have no doubt that if you conclude that as a country we were insufficiently resilient, and that in future different political and financial choices may have to be made in order to render us better able to withstand a system shock, you will want to say so. But the need for all these questions is obvious. First, the bereaved and those who otherwise suffered, of whom there are very many in number, are entitled to know if anything could have been done to prevent their loss or reduce their suffering. Second, if we were shocked by the outbreak of Covid-19, history suggests we should not have been. Epidemics, that is to say, the occurrence of a disease in a population at a level that is significantly above the baseline level, occur frequently. They can come on extraordinarily rapidly and spread very quickly. They kill large numbers of people. Pandemics, whilst rarer, are not new. Ever since humans have walked on this earth, pandemic disease, the Black Death, plague, cholera, typhoid, yellow fever, influenza, and Ebola has walked with us. And scientists are clear that there is an ever-increasing risk of pandemics in the future. Diseases from animals, zoonotic diseases, pose a perpetual threat. A large proportion of those viruses which infect mammals are capable of infecting humans, and many of them have been associated with human deaths. At the same time, diseases are becoming more prevalent and are being spread wider and faster on account of globalization and urbanization. So it's vital that international surveillance and alert systems work effectively. Furthermore, terrible though it is to acknowledge, the rate in the United Kingdom at which COVID-19 generally killed those persons who were confirmed to have been infected with it the case fatality rate, was relatively low, around 1%. The 1918 H1N1 flu pandemic was worse. Its case fatality rate was around 2.5% to 6%, and it caused a massive number of deaths worldwide. The estimates of death ranged in that pandemic from 17.5 million to 100 million. The case fatality rates of other diseases such as variant Creutzfeldt-Jakob disease, Ebola and smallpox were also much higher than SARS-CoV-2. Significantly, the case fatality rate of MERS, the Middle East Respiratory Syndrome coronavirus, the disease from camels that erupted in 2012 in the Kingdom of Saudi Arabia, was about 34.3%. SARS, severe acute respiratory syndrome, CoV-1, the earlier coronavirus pandemic in 2002, was around 9.6%. The relatively mild swine flu in 2009 to 10, about which we'll hear a considerable amount of evidence in due course, was less than 0.01%. What is critical, therefore, is transmissibility. The more infectious the disease is, the more people are infected and the greater number of people that will die. So the disease which poses the greatest risk to human life is the one that is both highly infectious or transmissible and once transmitted, severe or deadly. And at the moment, there are two notable subtypes of avian influenza or bird flu that are prevalent. Both have extremely high case fatality rates. Fortuitously, they haven't yet sustained human-to-human transmission. Let us hope they never do. But the possibility cannot be ruled out, which of course adds an even greater impetus for the need to ensure that our systems of preparedness are ready. My lady, the module is ambitious in terms of its scope. The documentary material which it encompasses is vast, but there's a limit, and I need to make plain what those limits are. First, Module 1 is not an inquiry into all aspects of the United Kingdom's emergency planning systems. It's only an inquiry into those parts of the general structures as is necessary to enable you to answer the questions: were the structures and systems ready for the pandemic that struck, and how can we make them better ready for next time? Secondly, Module 1 has a time frame, and I've already referred to the second date, the end date, the 21st of January 2020, when the Situation Report 1 was issued by the World Health Organization. It is beyond the ability of your inquiry to go back before June 2009, which was when the World Health Organization announced that scientific criteria for an influenza pandemic had been met for what became known as the 2009 swine flu pandemic. A third important point is that the inquiry needs to be aware of the difference between structure, central government departments, regional government, devolved administrations and the like, policy, which is government departments and bodies setting out rules as to how they'll go about deciding what to do, the planning, what is everyone meant to do, and finally, operational response, how services and help are actually provided. They are all important, but operational response is not a matter for Module 1. Equally, issues such as the core political and administrative decision-making, the merits and the timings of national lockdowns, vaccines, the specifics of healthcare, the response of the care sector, the detail of test and trace, PPE procurement, financial assistance, the government's response, and the impacts of the pandemic on various sectors of the country, particularly including the vulnerable, are for later modules. The more detailed exploration of the way in which the country responded has to await those later modules. May I now then turn to the system for preparedness. It is obvious, my lady, that the degree to which Covid-19 could be prevented from laying waste to society was a matter within the control of government and the systems for EPRR which existed. Those systems may not be able to stop a pandemic in its tracks, but they ought to be able to put in place measures of understanding of virus, understanding and forecasting how it might develop, tracking it, limiting transmission, and coping with the consequences of large-scale transmission. In order to see what worked well and what faltered or failed, I'm afraid it's necessary to have a basic level of understanding of how the systems were set up. Many following this opening statement may have some appreciation of the terms and of the bodies of the structures, but for those who do not, it's necessary to set out some short definitions and explanations which will assist in their understanding of the evidence which you will shortly hear. My lady, it is a particularly complicated system. To help us guide listeners through it, could we have, please, on the screen a document prepared by the inquiry, INQ 204014. My lady, this is a document which the inquiry team have prepared, which sets out the basic structures concerning EPRR for the United Kingdom and England, and also for Scotland, Wales and Northern Ireland. The INQ number is just a reference to the inquiry's electronic document system. I should say that this is a document which is evolving. We will improve it as we go along in light of helpful comments from core participants and the various government and devolved administrations in the United Kingdom. Could we go forward, please, to page 4? That, my lady, is a schematic representation of the United Kingdom and England's emergency preparedness, response and resilience system. Starting from the top, the Cabinet Office, of whom, of course, we've heard much in recent days, is the government department in the United Kingdom responsible for supporting the Prime Minister and the Cabinet. It is composed of various units that support Cabinet committees and which coordinate the delivery of government objectives, but primarily working with other government departments. One of its most important functions is national security and the coordination of the United Kingdom government's response to crises. My lady, it's obvious that in an emergency, the Cabinet Office needs to draw on the expertise of other government departments in its emergency planning. And so there is something called the lead government department. In relation to a pandemic, it's obvious that the lead government department would be the Department of Health and Social Security. And we can see in the middle of the screen, and I emphasise, just for convenience sake, we're focusing on the United Kingdom and England in this schematic design, rather than looking at Scotland, Wales and Northern Ireland, for which there are equally schematic designs of no less importance. So the blue part in the middle of the picture represents the Department for Health and Social Care. Lead government departments are the government departments which are appointed to deal and lead on issues which concern and affect them most. So, my lady, one of the questions which you'll be addressing is whether or not this lead government department model the correct one for a whole system civil emergency, or do the requirements of this acute type of crisis require a different approach? If so, what approach should that be? It is self-evident that in a crisis of the magnitude of the Covid-19 pandemic, the burden could not solely be carried by the lead government department, because, of course, the pandemic affected every part of the government and of British public life, from education to the care sector, of course, to the Treasury, to our finances, our jobs and livelihood. The Department for Health and Social Care oversees the National Health Service in England. It oversees the United Kingdom's arm-length bodies, such as the United Kingdom Health Security Agency. So a primary question going into the pandemic was the Department of Health and Social Security adequately prepared? Did it identify with sufficient adequacy the surge capacity in terms of hospital infrastructure, clinicians and support workers that would be required? During the Module 1 timeframe, the Civil Contingency Secretariat was the Cabinet Office unit that managed both the United Kingdom government's preparedness for and its response to major nationwide emergencies. My lady, it was established in 2001, and in July 2022, after the pandemic, was split into two separate functions, focusing on its emergency response functions, the COBRA unit, about which we'll hear a great deal more, and resilience frameworks, called the Resilience Directorate. And thank you very much. The Civil Contingency Secretariat has been highlighted at the top of the screen. Towards the top right of the screen, you will see a reference to the National Security Risk Assessment. The National Security Risk Assessment is the United Kingdom government's classified assessment of the top national level risks facing the United Kingdom. The assessment focuses on both the likelihood of the risk occurring and the impact it would have were it to happen. And it has a public-facing document, the National Risk Register, which provides information for those who have formal contingency planning responsibilities at a national, regional and local level. But Lydia, we know, of course, what the broad nature of future emergencies might be. Natural hazards include global health challenges, animal and plant diseases, growing antimicrobial resistance, space weather events, extreme weather, climate change, infrastructure collapse, or perhaps the unintended consequence of human endeavour and artificial intelligence. The world is an uncertain place, and risks seem set only to grow. The exact nature of those major risks cannot, of course, be identified in advance. And because it's not possible to know in advance with certainty which risks will crystallise and how, and because it's not practical to plan for every major risk, there will always be uncertainty. So the government draws up policies, and those policies are by their nature of more general application. But both the policies and the planned operational responses must build in the ability to respond to the unknown and provide for contingencies. Government planning must be flexible. Were the governments of the four countries flexible enough with their policy making? Was the consideration of what those risks might be and how they could be prepared for sufficiently imaginative? My lady, you will hear evidence that for many years an influenza pandemic was assessed as being one of the most likely risks to the United Kingdom. But what about other risks that, whilst they might be less likely, could be just as, if not more deadly? Did planning sufficiently address the risk not only of the known, but the unknown, a new pathogen, a new disease, a disease X, as it's known, with pandemic potential? Did planners pay sufficient focus on potential impact as opposed to likelihood? With COVID, the evidence will demonstrate that the government thought that the greater risk was an influenza pandemic and therefore devoted more time and resources to that possibility. In the event, we were hit, of course, by a coronavirus. That might suggest a lack of flexibility or proper foresight. Or perhaps the policies, plans and structures were so flexible and broad, so as to cover any reasonable possibility, that this prevented us from focusing enough upon those particular risks which, as I say, whilst being perhaps less likely, could cause us more harm. So a core question in Module 1 will be, to what extent was thought given to and planning devoted to the risk of a new emerging infectious disease that was not influenza? Did the system of planning become self-validating or complacent so that that question was not asked, or if it was asked by individuals, was not listened to? To what extent were the likely consequences of either influenza or a new and emerging infectious disease reassessed? My lady, the evidence may show that there was a degree of assumption in the process that if there was to be an influenza pandemic, it would be bound to lead to hundreds of thousands of deaths. This was because planners positively planned on what was known as the reasonable worst-case scenario, the RWCS, planning for the worst case that could realistically happen. The good sense of planning for the worst case that could realistically happen is obvious. You need to prepare everyone to respond to that possibility, to have enough resources, enough surge capacity, enough room for manoeuvre in the healthcare and social care systems, enough PPE and so on. But not at the expense of pausing and asking, what more can we do to ensure we don't get to that stage at all? The evidence may show, simply and terribly, that not enough people thought to ask because everybody started to assume it would be flu. And if it was flu, diagnostic testing, case detection and isolation are less effective on account of the... So, my lady, to what extent did the United Kingdom government and the devolved administrations have a strategy for preventing a pandemic from having disastrous effects, as opposed to dealing with the disastrous effects of the pandemic and the reasonable worst-case scenario, which was assumed to follow?
Mr. Keith, I've been encouraged to take regular breaks, as you know, for the purposes of the stenographer and others. Would that be a convenient moment? I apologise for...
It's a very convenient moment.
Thank you. I shall be back at 11:30. Yes, Mr. Keith.
My lady, I was addressing you in relation to whether or not the United Kingdom government and the devolved administrations had a strategy at all for preventing a pandemic from having disastrous effects, as opposed to dealing with the disastrous effects of the pandemic. Part of the answer may lie in the doctrinal thinking that underpins the emergency preparedness, response and resilience system. So the United Kingdom government and the devolved administrations adopted what is known as the integrated emergency management structure. And it had 6 phases: anticipate, assess, prevent, prepare, respond and recover. And this concept underpinned both the approach to emergency preparedness, response and resilience, and the revised law and legal arrangements which were introduced into this area in the early 2000s. So one of the issues for you in this module will be whether or not this was the right approach for the United Kingdom and the devolved administrations. Did this approach under the integrated emergency management structure have the right emphasis? Were these stages the right ones? So, for example, although I've made a reference to prevent and prepare, did this doctrinal approach sufficiently ensure that the government thought about how to stop the terrible consequences that it was planning for appearing in the first place? Furthermore, doctrinally, was there sufficient independent and rigorous expert advice? Was that expert advice in the government system sufficient in its range and diversity? Did the government learn sufficiently from the experiences of other countries, especially those such as Taiwan, South Korea and Singapore, who'd learned from the SARS-1 and the MERS epidemics, to which I made reference earlier, and whose preparations were in fact more advanced in some ways than our own? Extraordinary though it may seem, given that it's a word that will be forever seared into the national consciousness, there was very little debate pre-pandemic of whether a lockdown might prove to be necessary in the event of a runaway virus, let alone how a lockdown could be avoided. Very little thought was given to how, if it proved to be necessary, something as complex and difficult and damaging as a national lockdown could be put in place at all. Equally, there appears to have been a failure to think through the potentially massive impact on education and the economy of trying to control a runaway virus in this way. Was there an element of complacency based on our recent experiences, including the ranking in the Global Health Security Index, our response to swine flu in 2009, and the United Kingdom's undoubted successes in ensuring that SARS and MERS did not spread? Did our experience of the 2009 swine flu lead to concerns about overreacting? My lady, there had been numerous exercises, but to what extent were those exercises adequate in terms of scope and frequency, and the persons who were invited to participate in them? And what was learned from those exercises? What lessons were taken away from them in relation to future risks and future preparedness? At a more fundamental level, therefore, should there be an EPRR agency, an independent agency, to take complete control of national planning, preparedness and resilience? Such an agency might be responsible for managing the structure with the assistance of the rest of government, checking it and testing it. It could provide advice to the government and the devolved administrations on long-term strategy. It could commission external expertise from the fields of technology, health, economics and the military. Perhaps there should be a central leadership position, accountable to Parliament, with responsibility for whole system preparedness, resilience and response. My lady, I mentioned a few moments ago the legal structures which were introduced in the 2000s. One of the most important legal reforms based around this doctrinal approach to which I've made reference was the introduction of the Civil Contingencies Act in 2004. It provided the framework for civil protection in the United Kingdom, and it identifies and establishes a set of roles and responsibilities for those involved in EPRR at a local level, and allows for the making of emergency regulations to help deal with the most serious of emergencies. And if we could have, please, the document, the chart up, INQ 204104, please, at page 4. Thank you. You will see in the bottom left-hand corner of this chart, which is again is the United Kingdom and England one around about August 2019, a reference in the very bottom left-hand corner to local category 1 responders and local category 2 responders. So Part 1 of the Civil Contingencies Act 2004 provided for 2 groups of responders to an emergency. Category 1 responders, namely the police and the emergency services, local authorities and the healthcare system, the NHS, and Category 2 responders, utility and transport providers, water companies, the health and safety executive and communication providers. Now, those Category 1 responders are subject to the full set of civil protection duties. They're required to assess the risk of emergencies occurring and use this to inform contingency planning locally. They put in place the actual emergency plans upon which reliance is based in the event of a crisis. They put in place business continuity management arrangements. They make information available to the public, and they share information with other local responders to enhance coordination. The Category 2 organisations, by contrast, the cooperating bodies, are less likely to be involved in planning work, but they'll be heavily involved in incidents that affect their own sector. They have a lesser set of duties. They're obliged to cooperate and share information, but they don't, and they're not obliged to react in the same way as the Category 1 organisations. But there are no comparable legal duties on central government. The only legal duties are on those Category 1 and Category 2 responders. So in the event of a national crisis which engages the whole of government, is there a case for the imposition of legal duties on central government as well? Across England, local resilience forums support the planning between all those various bodies. They consist of the Category 1 and Category 2 responders, and they are the bodies which plan, which prepare for the crises or emergencies which might befall the locality. And if we look again at the bottom of the page, in the bottom left-hand corner, we can see local resilience forums, the bodies into which the local Category 1 responders and Category 2 responders report. My lady, there may be some degree of surprise that in this important system of emergency response and preparation, the bodies who are primarily concerned with planning for emergencies and indeed responding to emergencies appear to be right down at the bottom left-hand side of the page and to be local. And the reason for that is that the United Kingdom system works on the basis of subsidiarity. That principle is designed to ensure that those with local knowledge make the decisions on the ground. They are the people who will know the area well and therefore can best respond to flooding or some crisis or emergency which envelops a town or a part of a town or part of the countryside or the region. But those local resilience forums are, if you like, at one end, therefore, of these lines of communication. Is that the best model? Are local resilience forums and their devolved equivalents adequately resourced, accountable and led? To what extent did the central government, when we were hit by the pandemic, deal with the local resilience forums, ensure that they had what they needed to be able to respond? And in this system, there is a further conundrum, which is that local resilience forums deal with planning, but response when an emergency strikes is actually in the hands of a different group called the Strategic Coordination Groups. I think we should have that in yellow just above local resilience forums, if that could be highlighted. We can see Strategic Coordination Groups. These are different bodies, but largely composed of the same bodies that make up the LRF, the Local Resilience Forum, and they focus on the actual response to an emergency. Is there an unnecessary degree of duplication here? Another important area concerns the Resilience Emergencies Division, halfway up the page on the left. That is the division which rests within the Ministry of Housing, Communities and Local Government, now in fact the Department for Levelling Up Housing and Communities. And it provides advice to the local resilience forums through its resilience advisors, which we can see a little bit further down the left-hand side of the page. So in essence, the Resilience Emergencies Division is the liaison with the national and local tiers of response. So we have already, therefore, an understanding that in this system, you have the Cabinet Office, you have the lead government department, you have other government departments, and you have the Resilience Emergency Division of the Department of Levelling Up Housing and Communities, all concerned with ensuring that the system works. Is that really the best way of doing it? No less important, as I've earlier said, are the devolved administrations. Preparedness and resilience are devolved matters, meaning that they're the responsibility of each devolved administration and not of Westminster. And this inquiry is looking, of course, at the states of preparedness and resilience in all the countries. But on the subject of devolution, an important issue, therefore, immediately arises. Has the devolution settlement, which has made preparedness and resilience a devolved matter, struck the correct balance between the leadership, which is obviously necessary in any whole country civil emergency, whole nation, whole United Kingdom emergency, and the benefits of a tailored, localised response? So if we could please then look briefly at page 6 in this INQ document, and then go forward. Yes, thank you. We will see at the top of the page, Pandemic Preparedness and Response Structures, Scotland, 2009. And because, as I've said, resilience and preparedness are devolved issues, if we could please zoom back out, thank you, and see the whole page, you will see, of course, that the vast majority of the bodies in Scotland dealing with preparedness and resilience are Scottish bodies. But the link to the United Kingdom comes from the Cabinet Office, which sits on top of the whole structure, which is why the Cabinet Office is at the top of the chart, and linked through COBRA, the Civil Contingency Secretariat, to which I've made reference, the Scientific Advisory Group for Emergencies, down to the devolved administration level. Page 10, please. The analogous scheme for Wales, broadly speaking, in 2019. Again, you can see that all the bodies in the bottom two-thirds of the page are devolved bodies, and again the link to the United Kingdom comes through the Cabinet Office at the top. And page 14, similarly in relation to Northern Ireland. So, my lady, you will see from those pages and those schemes that there are a number of important bodies in Scotland, Wales and Northern Ireland which carry out analogous functions to those in Westminster and England. In Scotland, I won't take you to them, the Scottish Resilience Partnership. There are regional resilience partnerships. In Scotland, each regional resilience partnership has its own local resilience partnership. There are then a number of ministerial bodies for government resilience, There are government resilience officials, and emergency arrangements were arranged through the Scottish Government Resilience Room. In Wales, we have the Wales Resilience Forum, the Joint Emergency Services Group, local resilience forums, and in Northern Ireland, the Civil Contingencies Group, emergency response groups, and strategic coordination groups. My lady, there are a profusion of bodies. In relation to Northern Ireland, a vital issue is the impact in January, or what was the impact in January 2020 on preparedness, response and resilience arrangements of the prior collapse in power sharing. My lady, as is well known, the Good Friday Agreement, or Belfast Agreement, which was signed in April 1998, provided for a new devolved system of government with an assembly and executive at Stormont. However, thereafter, power sharing, as you know, was suspended on a number of times. Most relevantly, it was suspended between January 2017, when the then Sinn Féin Deputy First Minister, the late Martin McGuinness, resigned, and remained suspended until Saturday, the 11th of January 2020, just as the pandemic was starting to spread to the province. During that time, Northern Ireland was managed by civil servants without ministerial oversight. We will therefore be exploring to what extent that lack of ministerial input affected the civil emergency arrangements, and in particular, the inability, because of the collapse of the power sharing agreement, to make any significant improvements to this structure during that interregnum. Those with sharp eyes will see that each of the four nations has its own public health body. Public Health Wales, there's a public health agency in Northern Ireland, and Public Health Scotland. In England, the Health Protection Agency was established in 2003. In April 2013, Public Health England was established, incorporating the Health Protection Agency alongside public health functions previously carried out by the Department of Health and regional health authorities. Thereafter, and it's not on the scheme because the scheme represents the position in 2020, or 2019 rather, in April 2021, the UK Health Security Authority was established, which took on parts of Public Health England, focusing on health protection, alongside the functions of NHS Test and Trace and the Joint Biosecurity Centre. But the Public Health England's health improvement functions were transferred to the Department of Health and Social Care. My lady, another issue, therefore, for Module 1, why did those structural changes occur? Why did they occur when they did? Were they an improvement, particularly the abolition of Public Health England and the bifurcation of public health protection from public health improvement? What was the state of pandemic readiness and preparedness for each of those bodies? There had also been significant reforms to the national and local systems for public health. The Health and Social Care Act 2012 transferred most public health functions from NHS bodies in England and Wales to local authorities. At the same time, local authorities with public health responsibilities were required to employ a specialist director of public health. Were directors of public health utilised effectively within their local authorities? Did those public health reforms make our public health structures more or less resilient and able to respond to a pandemic? My lady, all these bodies and entities have to be run, managed and paid for. They have to be supervised and told what to do. Drafting has to be done of a myriad number of policy documents and guidance. They have to be assured, which is just another word for being tested or checked. Who provided oversight as to that state of preparedness of local responders, arm's length bodies, lead government departments, other government departments? And all those processes had to be provided for, discussed, agreed and put into place. We've seen, my lady, in the written evidence that relevant bodies, committees and subcommittees within government were renamed or sometimes disbanded altogether, only for other strikingly similar ones to be set up in the immediate aftermath. One might conclude, looking at the schematic schedules, that there was a labyrinthine and confusing picture. Was it really necessary? Were there proper links between central government and local authority, not just tick box consultation? Were there proper communications between central government and the devolved administrations that were not just dependent on the political will of ministers? So, my lady, standing back, was this civil emergency system as good as it could be? Were these structures adequate, or was their proliferation a hindrance to the United Kingdom's response? What can you do to make this better? Turning finally to the end product of all this, how to put actual plans in place so that everybody knows actually what to do in the event of an emergency. How were those plans drawn up, checked and compared? Was there adequate testing of plans for an actual pandemic? Were the structures in place for ensuring that plans for the necessary surge in healthcare and social care provision were there, for stockpiling and distribution of PPE and mass diagnostic testing? And of course, those areas are only concerned with the health consequences of a pandemic. But a pandemic is prone to affect, as I've said, every area of public life. And so where were the plans and how adequate were they for the shielding, employment support, disruption to schools, border policy, lockdowns, and as I've said, the profoundly unequal impact of a pandemic on the vulnerable and marginalised? Lastly, the pandemic struck the United Kingdom just as it was leaving the European Union. That departure required an enormous amount of planning and preparation, particularly to address what were likely to be the severe consequences of a no-deal exit on food and medicine supplies, travel and transport, business borders, and so on. It is clear that such planning from 2018 onwards crowded out and prevented some, or perhaps a majority of the improvements that central government itself understood were required to be made to resilience planning and preparedness. Did the attention therefore paid to the risks of a no-deal exit, Operation Yellowhammer as it was known, drain the resources and capacity that should have been continuing the fight against the next pandemic, that should have been utilised in preparing the United Kingdom for civil emergency? Or did all that generic and operational planning in fact lead to people being better trained and well marshalled and in fact better prepared to deal with COVID, and also to the existence of improved trade, medicine and supply links? My lady, on the evidence so far, but it will be a matter for you, we very much fear that it was the former. One of the most important features of Module 1 will be to consider whether health inequalities were appropriately considered in the planning for a pandemic. And I leave this issue to last in reflection of the fact that it is an issue which will find its reflection through the entirety of the evidence which you have directed be called in Module 1. The inquiry will look at how the lives of different types of people with different experiences were regarded by those with the duty of protecting them. For each of the decision makers, the civil servants, and those tasked with the responsibility of preparing our systems, were social and clinical vulnerabilities considered by them at all? When the emergency plans were drawn up, did they have regard to the social inequalities and health inequalities which would undoubtedly be exacerbated by the outcome of that planning? The evidence will reveal the reality to that question. So, my lady, there is a great deal to cover. I think I have said quite enough. You will hear now opening statements from council representing the Module 1 core participants, and then we will turn to the evidence and the witnesses, whom Kate Blackwell, King's Counsel, and I will then examine.
Thank you very much indeed, Mr. Keith. Mr. Weatherby. I think others do the turning on of the microphone? Oh, really? Okay. Sorry to interfere. You've still got red, haven't you?
There we go. Good morning, milady. Just. I'll be about 30 minutes. I hope no more. On the 8th of June of 2015, then Prime Minister David Cameron gave a speech to the G7 in Bavaria. A United Kingdom government press release ahead of the speech said this, and I quote, "In a stark warning to other G7 leaders, the PM will say that the world must be far better prepared for future health pandemics that could be more aggressive and harder to contain than the recent Ebola outbreak. Experts have warned that lessons must be learnt from what happened. A more virulent disease in future, transmitted by coughing, like flu or measles, for example, would have a much more devastating impact if a better approach is not put in place," unquote. That was 2015. The WHO indicate that globally there have been almost 7 million verifiable deaths from COVID. In a recent article in The Economist, Dr. Tedros Adhanom Ghebreyesus, Director General of the WHO, said the real number is likely to be around 20 million. Less than 5 years after Mr. Cameron's speech, a virulent disease transmitted by respiratory means had arrived and caused devastation around the world. The bereaved families would like to know, had the better approach that Mr. Cameron spoke about been put into place in the United Kingdom? What did his government or those after him do about the threat he had so powerfully raised with world leaders? Whatever the answer to that question, for well over a decade prior to the arrival of COVID, the United Kingdom National Risk Assessments, as we've just heard, had recognised that the threat of a pandemic was high and that the threat was not only flu, but also a quite separate type of new and emerging disease, unknown. It cannot be said, therefore, that this terrible disease, this pandemic, was a black swan event, an event so unlikely that it was practically unforeseeable. Nor did its emergence rely upon the coming together of a number of unlikely phenomena in a so-called perfect storm. The inquiry experts, Bruce Mann and Professor Alexander, later this week, we anticipate from their report, will conclude that whole system preparedness for a novel disease pandemic in the UK was, quote, wholly inadequate, as at January 2020. How was that allowed to happen? How did that come to pass? What we anticipate will be said was that those same national risk assessments recognised that the impact of flu was assessed as high, with what is termed as the reasonable worst case scenario of up to 750,000 deaths. But the reasonable worst case scenario for the unknown new disease was put at a far lower figure, between 100 and perhaps 2,000 deaths. No doubt justifications will be given. However, taking Mr. Cameron's warning that the next emerging disease might have the characteristics of Ebola, 70% fatality, and the transmissibility of measles, 90% of those without immunity, it's hard to fathom why the UK government's national risk assessment took such a complacent view of its likely impact and did so repeatedly. For the families, therefore, Module 1 should address the key question of whether the United Kingdom did everything reasonably practicable to prevent a foreseeable pandemic of this type or mitigate its impact if it arrived. Why was there apparently no overall plan, no whole system plan? Was there a minister with overall responsibility, a clear and effective framework to ensure everyone worked together, ensure everyone was properly resourced and trained and had the right equipment, ensured the planners had the right scientific and expert advice and formulated appropriate contingency plans? Were there proper and sufficient auditing and assurance mechanisms in place to ensure the highest quality preparedness possible? It appears none of this. Mr. Keith's very helpful document put up on screen might of itself answer whether there was a clear and effective framework. As we understand the evidence, it appears that the closest to an overall plan was the Department of Health 2011 Pandemic Flu Preparedness Plan. Was that fit for purpose for a non-flu pandemic in 2020? Why wasn't there this whole system plan? Many civil emergencies are local, as Mr. Keith touched on, and require a local response backed up by central government support only where necessary. The Manchester Arena bombing outrage or flooding, perhaps. But wasn't it obvious that other civil emergencies, including pandemics, are by their very nature national whole system emergencies and require national whole system planning as a result? Why was there apparently such reliance on 2011 Department of Health planning? Wasn't it obvious that pandemic planning had to go far beyond public health and healthcare? Options for border controls and screening, travel restrictions and quarantine, maintaining food supplies and public security, enforcing emergency restrictions on movement and assembly, maintaining education and social service systems and protecting the economic well-being of the country and jobs, are all matters way beyond the remit of the Department of Health and Social Care. The 2021 National Audit Office report on preparedness for COVID noted that the Cabinet Office, through its Civil Contingency Secretariat, coordinated government planning and response. It found no evidence that there was a consensus on the so-called risk appetite of the government across departments, which means the level of impact the government would deem an acceptable outcome from the particular risk. Indeed, the same report notes that the Cabinet Office told the National Audit Office that the government's risk appetite had changed as the pandemic arrived on our shores, meaning that it lowered the threshold for the health and societal impact of the pandemic that it deemed acceptable. How, the families ask, was there coordination of relevant government departments if they were working to different agendas? Why, the families ask, would planning be done on one basis and then response on another? In fact, the same report indicated that a cross-government working group review in February and March 2020 rated more than 80% of the plans as being unable to meet the demands of any actual incident. And it also noted that the Cabinet Office did not have the remit to carry out oversight or assurance over lead or other government departments. So no central government responsibilities, a coordinating secretariat within the Cabinet Office which actually had no oversight or assurance remit or powers, and different government departments working to different agendas and acceptable outcomes. The inquiry will have to determine whether that was a sensible approach to planning and preparedness for a national emergency or a recipe for chaos and failure. Did planning sufficiently concentrate on the human impact and not process, and did it fatalistically concentrate on dealing with the aftermath of the so-called reasonable worst-case scenarios rather than prevention and mitigation? First and foremost, planning should concentrate on prevention and mitigation, not how to deal with the number of bodies. It is important that no one forgets, amongst all the figures and statistics and percentages, that the true cost of the pandemic should be measured in the lost years, love, happiness, potential and missed milestones of every person who did not survive to see the world return to some version of normal. It's measured in the enduring grief of those we represent, for whom the world will never return to normal, because they lost a crucial part of that world. It will be measured for years to come by those still suffering the effects of long COVID. The COVID Bereaved Families for Justice represents a large and diverse group of bereaved individuals from across the United Kingdom. They come from all walks of life. Many, by dint of their occupations as well as personal circumstances, saw and felt this pandemic on many levels. Many identify structural discrimination and unaddressed health inequalities as contributing to their loss. The families have different areas of interest, different experiences, different questions, but they're united not only by grief, but by their determination that the legacy of this inquiry, an inquiry for which they campaigned, is one of justice, accountability, and most importantly, change. They want to save lives. Jo Goodman believes her father contracted COVID whilst attending an outpatient appointment at his local hospital and sadly died. He was clinically vulnerable. He'd not been given advice about the risks or about shielding, and there were no apparent infection controls at the hospital. Jo believes that if there had been proper planning and preparedness and swift action to limit community infections, to implement effective hospital infection controls, and to protect the vulnerable, then her father might not have died. There are, of course, thousands of Jo Goodmans. Jo met Matt Fowler, whose father had also died from COVID, on Facebook in spring of 2020. Matt's dad was a previously healthy man in his 50s. Jo and Matt did not know each other. They lived and live in different parts of the country. Together they formed a support group for others like them, and that subsequently evolved into the CBFFJ UK and a campaign to get answers and to try to achieve changes that meant that their devastating losses would not happen to someone else. And they've been joined by 6,500 others from all corners of the United Kingdom. Amongst them is Salia Arson, who throughout the pandemic was a frontline doctor within the emergency department at a hospital in Wales, and then specifically for the second wave within intensive care, where she treated critically ill COVID patients, some of whom died. During this period in December 2020, sadly, Saleha's father, Arsan ul Haq Chowdhury, caught COVID and died. Salia has produced and reported on a very powerful Channel 4 Dispatches documentary, for which she filmed for 4 months during the pandemic, between October 2020 and January 2021, within her own intensive care unit. It's available on Channel 4 and open source. Before training to be a doctor, Salia served with the Royal Army Medical Corps. She contrasts the state of preparedness in the British Army, which incorporates robust regular training, the putting on, taking off and being operational in protective suits, including respirators, with the state of preparedness she experienced in the NHS, when no such training in PPE took place throughout her years at medical school and during her subsequent 14 years as an A&E doctor. Salia is one of 6 siblings, 5 doctors and a pharmacist. They work in different parts of the UK. In all their individual years of practice, none of them has had any such training in PPE. Neither Salia or her siblings were ever party to, involved in, or made aware of any preparedness training or learning from exercises such as Cygnus, Cygnet, or Alice. They have never been involved locally, regionally, or nationally in any policy, clinical, or management training exercises relating to an outbreak of an infectious disease. Salia asks why, when the merits of clinical practice in protective clothing, training, exercising, and awareness of emergency plans for frontline medics and essential service workers are all well known and documented. A disproportionate number of the CBFFJ families are, sadly, from black and brown communities whose loved ones died, often as frontline health or social care staff, doctors, cleaners, carers. Others' loved ones were transport workers or worked in the gig economy. They want to know if structural racism or the disproportionate effects of a pandemic on ethnic minority communities was considered as a part of preparedness and planning, never mind the response to the pandemic, and if not, why not? Jean Adamson's father died in a care home to which patients were transferred from hospital without testing. Jean is a consultant who has worked in the area of social care governance for many years and has been an advisor to the Care Quality Commission and has first-hand knowledge of the lack of contingency planning in the sector. Amongst her questions are why were there no or insufficient plans to prevent the transmission of COVID between homes due to the use of agency workers and transfers between homes and hospitals without testing? Where was the protective ring around care homes as claimed by the former Health Secretary Matt Hancock? Kim Nutt, the partner of an ambulance care assistant, wants to know why he was not supplied with sufficient PPE or proper guidance as to what protective equipment he should wear. The necessity for proper guidance, stockpiles, and surge supply of basic equipment should have been obvious if there had been proper preparedness. John Sullivan's daughter lived with a serious disability. He witnessed the lack of any planning to protect her as a disabled person, and to the contrary, he is concerned that a treatment triage tool may have taken account of her disability in a discriminatory way. He wants to know what planning and preparedness there was to protect people especially vulnerable through disability, and what regard, if any, there was for combating the effects of structural discrimination against disabled people. Councillor Sarah Butikofa was the leader of a district council in Norfolk throughout the pandemic and as a bereaved family member. She witnessed firsthand the lack of resourcing and the complete lack of guidance or clear policy from central government relating to multiple issues, such as PPE supplies, lockdowns, vulnerable adult care arrangements, food supplies, and multiple other non-pharmaceutical interventions. She questions, where was the central responsibility for planning and preparedness, and why was there insufficient resourcing? I could, of course, go on, but I'm sure everyone understands these are real and raw issues for the families. There are, of course, many, many others. Barbara from South Wales, Martina from Northern Ireland, Ian from Scotland. That is why they've asked you to hear some of their stories within the hearings, to evidence and illustrate the apparent lack of proper planning and preparedness across many sectors. That's why so many of them have stood outside this building today, holding photos of their lost loved ones, to highlight that their stories must not be forgotten. Essentially, the inquiry has to address three questions. What happened, what went wrong, and how do we ensure that everything reasonably possible is done to prevent it happening again? 3 words: facts, accountability, change. From that perspective, the families suggest that the fundamental topics within the scope of Module 1 are 1, at a UK level, who had responsibility for civil emergency resilience, preparedness and planning? Where did the buck stop? 2, who was responsible for assessing the risk of a pandemic such as COVID and its likely impact, and how was it done? What was that assessment, and was it as accurate as it should have been on the available evidence? Was the methodology and evidential basis in the public domain? Was it properly scrutinised and challenged? 3, why was there no whole system plan to prevent such a pandemic or mitigate its effects? Who was responsible for such national planning as there was? Did it take proper and sufficient account of all relevant scientific advice? And did it effectively integrate the individual plans of lead government departments and others? 4, was that planning and preparedness optimal? Was there sufficient understanding of it amongst leading policymakers, including ministers? Was pandemic planning effectively communicated to frontline essential services and the general public? Was it sufficiently resourced? Was there appropriate exercising and training? Was there sufficient engagement with communities and proper consideration of issues of discrimination and vulnerabilities? Was it adversely affected by the diversion of resources to deal with Brexit? Was it affected by political reservations about the WHO or other international bodies, including those in the EU? 5, in terms of the civil emergencies framework, were the responsibilities on central government clear? Indeed, as we've heard, were there any such responsibilities on central government, or was the framework strikingly deficient in that sense? Was there integration of central and local emergency planning and auditing and assurance so as to ensure an optimal and joined-up response? What framework was there to ensure that the UK government and each of the devolved administrations integrated their approaches? Was there a persistent failure across government to identify, learn and improve on responses to crises, as referred to in the 2022 Internal Government Crisis Capabilities Review? 6. To what extent were the citizens of Northern Ireland disadvantaged by the lack of statutory duties on the equivalent of Category 1 and 2 responders in Northern Ireland? Why did that gap exist at all? 7. Was there a culture of secrecy surrounding civil emergency planning and preparedness? Did this include scientific advice, in particular from SAGE, and publication of results and lessons learned from a number of pandemic exercises? In our written submissions, we reference advice given to Matt Hancock, former Health Secretary, that publication of Cygnus would lead to criticism of lack of preparedness, a reference which we say is significant in illustrating this issue. Did a closed institutional culture reduce the opportunity for challenge to orthodoxies, and did it reduce the autonomy of scientists to frame their own questions rather than be restricted to answering the questions of others? Did a closed culture promote or fail to counteract structural discrimination or to consider health inequalities? And 8, to what extent did austerity reduce the capacity for preparedness? Were resources diverted from civil emergency planning to maintain other business as usual frontline services, because decision makers hoped emergencies may well not happen on their watch? Was former Chancellor and architect of austerity, George Osborne, correct when he said that those financial policies fixed the roof whilst the sun was shining? Or is Dr. Jonathan Fluxman of Doctors in Unite correct when he described non-NHS public health funding reductions as stripping the lead off the roof to make the buckets to catch the rain? The families expect the evidence will show a lack of responsibility in government for civil emergency preparedness, with little or no ministerial leadership, and a chaos of committees which led to poor planning and ultimately a reactive rather than proactive response to the virus. We anticipate the evidence will show that the most fundamental consequence of this was a slow reaction with a pandemic time, was a slow reaction. And with a pandemic, time is of the essence, and lost time is measured in lost lives. I've already noted that there was a national risk assessment which correctly identified newly emerging diseases such as COVID as a threat to the UK, but significantly underestimated the likely impact. If that is correct, why? Between the turn of this century and the pandemic, the two serious outbreaks of coronaviruses, SARS and MERS, had, as we've heard, far higher fatality rates than COVID. Neither disease made a significant impact in the UK, most probably because of their transmissibility or their infection rate being low, but also because swift and effective measures were taken in other countries where they arose. If this was the reason why national risk assessment successively rated the potential impact of pandemic flu as extremely high, but the potential impact of an emerging disease as low, this was a case of reliance on chance outcomes in past outbreaks, rather than a properly informed view as to whether a different chance would lead to a catastrophic outcome the next time. According to the NAO report, when asked, the Cabinet Office asserted that, quote, diseases such as Ebola were expected to burn themselves out quickly, as had been the case on previous occasions. Learning lessons from the past is vital. Fighting the last war rather than planning for the next one is a fundamental mistake. There is no scientific evidence of an inverse relationship between virulence and transmissibility. David Cameron seems to have understood that in 2015, and indeed it's a fact expressly stated in the 2011 pandemic flu plan itself. Why then did ministers, including Mr Cameron, and scientific advisors not challenge the narrative in successive national risk assessments that an unknown emerging disease would likely be of relatively low impact and cause a low number of fatalities? That's an important question with which the inquiry will have to grapple. If there had been actual ministerial responsibility for civil emergency preparedness, and if there was actual central government departmental responsibility rather than this apparently ad hoc coordination role within the Cabinet Office, might there have been greater challenge and scrutiny? Responsibility leads to accountability, leads to better decision-making. Knowledge that the buck lands at the minister's door concentrates minds. If the scientific advice had been more transparent, and scientists were able to determine their own questions and encouraged to challenge orthodoxies, scientific autonomy, would the tendency to groupthink and perhaps complacency have been combated? In summary, was the process for risk and impact assessment robust? Was it transparent and open to peer challenge or challenge by policymakers? Or were the assessments opaque? Going forward, should there be a presumption that both the methodology and the evidence for the risk and impact assessments of each known threat should be in the public domain, except where there is the clearest of national security issues? Such an approach would foster informed discussion, raise evidence beyond that which has been considered behind closed doors, and lead to greater public understanding and engagement and preparedness and planning, and perhaps a greater appetite for proper funding. The inquiry will have to consider whether the labyrinthine risk and impact assessment processes were a sensible tapestry and finely tuned operation, or whether in reality it was a hodgepodge arrangement, more colander than coherent framework. The stark facts, not hindsight, show that in the years before COVID, there was no room for complacency. Going forward, those realities mean there is an urgent need to analyse the past and optimise prevention and mitigation for the future. The UK is, of course, amongst the richest nations on earth. It has mature institutions, including with respect to healthcare and public health. Together with Ireland, it's an archipelago, islands, giving it obvious geographical advantages. The UK was well placed to see a pandemic coming and to have effective defences and mitigations, planning, resilience and preparedness. It was well placed to see the necessity to have options such as border controls and screening of entrants. It was well placed to have learned the importance and methodologies of test and trace used so effectively by other nations, in particular in Southeast Asia, and for other non-pharmaceutical interventions, including masks, restrictions on mass assemblies, travel, lockdowns, all to be used intelligently and proactively, which crucially in this context means early. Was a lack of incorporation of these measures into planning and preparedness responsible for them being deployed later than was necessary? The families have no doubt this is the case. The UK was well placed to have good plans for PPE stockpiling and surge manufacturing and supply of the same and other things such as oxygen and medical equipment. Why was the availability of PPE in particular so deficient? If we're right that the use of these measures should have been learned from recent coronavirus history, and indeed recent history of flu, Ebola and other diseases, were there actually any UK plans for each of them? Was there resourcing? If so, were the plans and resourcing adequate? Or was the UK always one step behind, prevaricating, dithering, delaying and hoping for the best, reacting rather than acting proactively to save lives, minimise disruption and protect communities and the economy? As has been outlined, so far as we understand the position, the Civil Contingencies Secretariat within the Cabinet Office liaised with the lead government departments who owned each risk identified on the risk assessment, because the particular risk fell within their area of responsibility. Those lead government departments were expected to have plans for those risks. We do not doubt that it was sensible for the Department of Health to have had a plan for a pandemic for obvious reasons. But for equally obvious reasons, that plan should have been integrated into our whole system plan, or at least fully coordinated with the plans of multiple other relevant departments and agencies. There was no framework requiring that to happen, and it was beyond the responsibility of the Cabinet Office, whose remit was coordination and liaison. To the families, that seems to have been a fundamental failure. There are commonalities to civil emergencies as well as differences. If a minister and department had responsibility for civil emergency preparedness and planning, or even a statutory agency, then it would be responsible for whole system plans for each identified threat, incorporating the planning not only of the lead department, but all the others. There are similarities with JESIP here, the Joint Emergency Services Interoperability Principles. A whole system response can work only if each relevant department, each responder, each agency knows not only its own role, but also that of others. Interoperability fails without clarity, joint plans, adequate resourcing, training and exercising. At the local tier level, interoperability between agencies occurs through the local resilience forums that Mr. Keith touched upon. Joint plans, training and exercising. Why is there no such framework for central government or between central government and the local tier? We'll learn, no doubt, that there were efforts to coordinate across government through a myriad of committees. No doubt we'll be told that there was learning and changes made beyond the 2011 pandemic flu plan, but we urge the inquiry to drill down into what those produced in reality. We do understand from the evidence that there was a realisation that the 2011 planning strategy needed updating, and a pandemic flu Preparedness Board was established, but its work was stalled because of the preoccupation with readiness for Brexit, and it appears few real changes were made. It's the reality that by January 2020, despite this realisation that there was a need for change, there was an absence of action, an absence of planning, which would have allowed the UK to react swiftly, leaving government to largely make up the plan as it went along once COVID arrived. Finally, what might such a whole system plan have looked like? Taking the 2011 plan as a starting point, given the experience of MERS and Ebola and a number of exercises that had taken place since, we might have expected a plan which said more than the bare assertion in the 2011 plan that it could be adapted for non-flu outbreaks. Some aspects of a modern pandemic plan perhaps write themselves. Early genomic sequencing to enable development of tests, and establishing immediate vaccine and antiviral research and development, and ensuring manufacturing and laboratory capacity for both testing and vaccines, once available, would be most obvious. Some of these aspects may have been progressed well in this pandemic, although it's less than clear that this was due to government or indeed planning, and we anticipate that there were aspects of testing rollout and capacity which was seriously inadequate. But a whole system plan should also recognise that a newly emerging disease might have different modes of transmission. It might have different longevity of contagion, and it might be transmissible asymptomatically. The plan would therefore require a range or menu of options, as proved effective particularly in Southeast Asia long before 2020. In some respects, the plan would plainly need to be multi-departmental or multi-agency. Screening at airports would need interoperability with airport authorities and the border force, as well as public health facilities. Restrictions on assembly would need legal changes and policing, shielding the vulnerable, combating disproportionate effects due to discrimination, and protecting education and social services provision will necessarily involve interoperability. A whole system plan would also include PPE procurement and stockpiling, and surge supply of equipment and oxygen, antiviral and vaccine development, It would include economic resilience and securing jobs, which required treasury planning and plans for securing food and energy supplies and distribution. With the lead government department system, which fragmented preparedness to narrow responsibilities, there was little chance of a rapid, joined-up, effective response with an array of tools ready-made at its disposal. In conclusion, you will be told by some politicians that austerity put the UK in a good place to respond to the pandemic, but experts will point to its effect on public health and local authority resilience funding. The inquiry will learn also of what happened to health inequalities concurrently with these cuts and reasons why the widening of such inequalities might have occurred as a result. We anticipate some senior civil servants will defend the civil contingencies framework and argue that in fact it worked well. But you'll also hear the view of the experts, including Bruce Mann, one of the architects of the current system, who will say not only that UK preparedness was wholly inadequate, but that there should, going forward, be clear responsibilities on central government, clear national standards and competencies, mechanisms of assurance and adequate funding. Indeed, at the time the Civil Contingencies Act was enacted in 2004, there were recommendations that it should contain central government responsibilities as well as subsidiarity to local responders that Mr. Keithers explained earlier. We would argue an opportunity lost at that time. The lack of central responsibilities meant there was no single point of responsibility and no mechanism for collaboration cross-department or with other agencies. It meant there was little or no assurance or standard setting for local responders in local resilience forums, and there was no framework for collaboration and coordination with the devolved authorities and administrations. We anticipate Bruce Mann and Professor Alexander will highlight the temptation to pay lip service to responsibilities which are not captured in law, especially when resources are tight. I've addressed at some length the closed nature of the assessments and planning in this area, and asserted that it chilled public discourse and challenge. But we also anticipate that the lack of transparency in preparedness masked the effects of austerity, allowed structural discrimination to continue unchecked, and led to learning from exercises or other events from translating into action. The answers to these questions and what we do about them is vital. If the last 3.5 years have taught us anything, proper planning, adequate resourcing, and swift action saves lives. From the family's perspective, it appears that the UK had none of those three things. They want to know why, and they want it to change.
Thank you very much indeed, Mr. Witherby. I'm very grateful. Mr. Lovery.
Good afternoon, my lady. At this stage, your ladyship knows, but for anybody else watching, that I represent the Northern Ireland Covid-19 Bereaved Families for Justice. And in an approach to this, which may find some model in some part of the findings of the inquiry in the future, we've adopted a joined-up and coherent approach to making our oral and written submissions, so your ladyship will see that we have produced a joint document, and I commend the submissions of Mr. Wetherby to the inquiry and to you, my lady. It is obvious. I represent the Northern Ireland bereaved families who lost loved ones, young and old, in a variety of circumstances, including care homes, hospitals, and the community. Our families, my lady, have been impressed by the robust approach that you and Mr. Keith and his team are taking. You, my lady, and your team have worked incredibly hard to get this inquiry started in, despite press reports, such a short period of time, and we have all, the core participants, have been working hard and together with the inquiry and with the inquiry team. And from what was said by Mr. Keith already this morning, we know that he has, and you have, my lady, been listening to the submissions that have been put in writing so far and are considering those very carefully. And our families have faith that this inquiry will yield the results which they search for. You know, my lady, that this inquiry isn't simply about taking a robust approach to individuals such as former prime ministers. It's not a criticism. It's not an inquiry which will deal with personal criticisms necessarily of those individuals. But of course we know that no individual is going to stand and no government department is going to stand in the way of progress of this inquiry. This inquiry, as my clients know, is about the impact, and this module about the impact the lack of preparedness had on them and on society as a whole. And as I said, we are here to support you, my lady, in your task in finding out, in particular for our families from Northern Ireland, was Northern Ireland prepared? What lessons for the future can be learned? And should anyone or anybody be made accountable? And there are three areas I just want to look at briefly in the Civil Contingencies Act, which Mr. Keith already referred to, some science and some of the politics involved. A large part of the Civil Contingencies Act 2004 did not actually apply to Northern Ireland. And the problem was not just the devolution scheme, but that in 2004, the Executive and Assembly were in suspension. Northern Ireland was under direct rule from Westminster. And the 2004 Act did not confer duties upon Westminster ministers, including those with direct rule powers in Northern Ireland at the time. There was no equivalent devolved legislation ever introduced, despite this being a key recommendation of the Cygnus report, and despite the Northern Ireland Secretary of State, the Northern Ireland Secretary of State's expectation in 2005 that Northern Ireland would have, quote, a similar level of protection for its citizens as experienced elsewhere. The statutory obligations pertaining in Northern Ireland were, in contrast to the rest of the UK, were mere guidance, my lady. The lack of cohesiveness is plain from the statement of Ms Allen from the Association of Local Authorities in Northern Ireland. It conveys a sense that in the absence of statutory obligations on local authorities, there was relative inaction with regard to planning and preparedness, with little, if any, formulation of preparedness policies. And the people in Northern Ireland, therefore, were at a distinct disadvantage. They had less statutory protection compared to other citizens in the UK. In terms of science, my lady, there was a disjuncture between central and devolved government. And this is demonstrated in part by Professor Young, who is the part-time consultant and chief scientific advisor, by his request to join the Chief Scientific Advisor UK network. And this was declined. This request was declined. Only one representative for each devolved administration was allowed. There's no record of Northern Ireland participation in SAGE prior to the 29th of March 2020. Between 2009 to 2015, the senior medical officer only had observer status with no speaking rights at the Joint Committee on Vaccination and Immunisation and the Advisory Committee on Dangerous Pathogens. Northern Ireland had no automatic representation at SAGE, and as McBride put it, policymakers in Northern Ireland may have had more limited awareness of the extent to which uncertainty and a range of opinion is expressed in scientific discussion. My lady, Northern Ireland did not attend COBRA meetings until the 2nd of March 2020. The inquiry, we say, should consider recommendations that ensure in future that Northern Ireland Chief Scientific Advisors become part of the UK network and SAGE, and to ensure Northern Ireland attendance at COBRA meetings. But, my lady, there was a lack of knowledge among political leaders as well in relation to central government planning and preparedness and the reasons for it. Michelle O'Neill, the First Minister designate, accepts a lack of knowledge of, or at least inability to recall, exercise sickness, despite it occurring while she was Minister for Health. Arlene Foster, likewise, despite being First Minister during Operation Cygnus and the pandemic, does not recall being briefed, quote, as to the recommendations made on foot of exercise sickness or any steps the Executive Office intended to take to improve pandemic preparedness prior to the Assembly collapsing in January 2017, nor does she recall any steps taken in relation to pandemic preparedness between January 17 and January 2020. We say this shows a low level of interest in or the impact which sickness had on Northern Ireland decision making. Michelle O'Neill's successor, Robin Swan, who was the Minister for Health during the pandemic, does recall sickness and states his belief that the flu plan provided a good foundation for action during the Covid-19 pandemic. The inquiry, my lady, should of course examine this assertion in light of its exclusive focus on the influenza pandemic. In any event, it's clear that Northern Ireland devolved government failed to implement a coherent response to the pandemic, and you, my lady, may well find that it was incapable of providing a coherent response. There's a common theme that runs throughout, common themes, and they're the lack of statutory protection, lack of pandemic coordination, and a lack of preparedness for a pandemic. And the context of this is decades of political dysfunction in Northern Ireland. But, my lady, as Brenda Doherty, who you saw earlier on the film and who made a statement, and you will hear from later on in this module, she put it in these terms, that, and this is quoting from her statement, the vacuum in government was known not only to our members but also to the Westminster government. If that prolonged lack of an executive was having a detrimental impact on the preparedness and resilience in respect of emergencies in this jurisdiction, the UK government had a moral and constitutional duty to act to ensure that those living in this jurisdiction would not suffer as a result should there be any emergency. Mr. Keith referred earlier to the impact of EU exit preparations, and on the 22nd of January 2020, the pandemic flu subgroup acknowledged that due to the lack of work done and the impact on staff resources because of EU exit preparations, that Northern Ireland was more than 18 months behind the rest of the UK in terms of ensuring sector resilience to any pandemic flu outbreak. And my lady, Mr. Keith's remarks were made in terms of the UK generally, and it appears from that we were even 18 months behind that again. I mentioned Brenda Doherty, my lady. Her mother, as you heard, Ruth Burke, died on the 24th of March 2020. She was the 4th person to die from COVID in Northern Ireland, the first woman. She was admitted to hospital on the 11th of March because of high levels of warfarin. There was no testing of patients on admission. The only PPE she saw was a disposable apron. She asked the staff about COVID-19 because she'd seen footage of it on television and was of events in China and mainland Europe. She was told not to worry, it will all be over by the summer. On the 19th of March, she arrived at the hospital and was told visiting was being stopped, but a nurse let her in for 5 minutes. At the end of the 5 months, her mother asked why she was leaving. She said she couldn't stay because of the coronavirus restrictions. She told her mum that she'd be home soon and that they all loved her. She waved bye-bye, and that was the last she saw of her mother. On the 23rd of March, she made a phone call to the hospital but was told that only limited information could be given on the phone. But of course, my lady, there was no other way to get information. Half an hour after that, the Prime Minister announced the lockdown restrictions. She then later received a call asking if she agreed to no unnecessary intervention in relation to her mother. And she thought, is she going to make it? Can the family be there? And she was told no. 12 hours later, she received a phone call to say that her mother had passed away without any of her family being by her side. There was, as she said, my lady, no coming home, no seeing her in her coffin, no laying out of her clothes for her to be laid to rest in. The funeral she described, she waited outside locked cemetery gates for the hearse to arrive. There was no carrying of the coffin. The council workers were dressed in white clothes and there was red and white tape around the grave. It all lasted 15 minutes. A committal she describes it as rather than a funeral. And afterwards they all walked back separately to their own houses. That's one story, my lady, but the themes in that story and other stories referred to in the other people in Ms. Doherty, in Brenda Doherty's statement are there. And then the themes of lack of communication, that not only did these people suffer the death of their loved ones from COVID, and in high proportion the elderly and the vulnerable, people who should have been protected. And like so many others, her mother was given COVID in hospital. Preparedness should be meaning the protection of the most vulnerable from death, but also preparedness ought to have contemplated, prepared for, and prevented unnecessary or disproportionate dehumanizing, re-traumatizing restrictions. So many of our families, my lady, are picking up the pieces from this clinical estrangement in the final phase of their loved ones' lives. No wake, human remains treated like toxic waste. My lady, preparedness and resilience is not just about science. It's about anticipating and minimising the holistic overall impact of a pandemic and its containment and eradication the impact of that on human beings. My lady, our families know that there's no other person better equipped and suited with the forensic expertise and compassion to deliver the truth for the families of what happened, both in this module and the modules to come. Thank you very much for listening to us today.
Thank you very much indeed, Mr. Avery. Made some very important points. Thank you very much. I shall break now and return at 10 past 2. Sorry?
I think we may have to reconvene at 2, only because we've got quite a number of openings to get through.
Okay, very well. Sorry, completely misreading the clock. Forgive me, everybody. Return at 2 o'clock.